Welcome to this satellite symposium presented by Veloxis, strategies to optimize living donor kidney transplantation opportunities. The speakers for this session are Christina Klein from Piedmont Hospital and Rupinder Sodhi from the Loyola University Medical Center. Please stay tuned after this session talks for the panel discussion. If you would like to submit a question directly to the session moderators, please utilize the Q&A feature on the side panel of your screen. Enjoy the session.
Hi, everyone, and thank you for joining us. On behalf of Dr. Klein and myself, I'd like to welcome you to this symposium on strategies to optimize living donor kidney transplant opportunities. The objectives that we're going to discuss today are to identify potential strategies and new policies that may help overcome disparities in renal transplant access, explore approaches to optimizing living donor matches in the era of COVID-19, and to exchange best practices for the recruitment, engagement, and care of potential living donors.
What we wanted to start off with was to describe the current state of kidney transplantation in the United States. And one of the important highlights is that kidney transplants have really hit all-time highs through the last decade. So if you look around 2011, 2012, you start to see an increase in total number of kidney transplants, achieving nearly 25,000 in 2021. But also of note is that most of the increase in deceased donor transplants are responsible for the really remarkable increases in total kidney transplants, while living donor transplant numbers have stayed relatively flat throughout the last several years. So this really highlights that we, number one, can increase number of kidney transplants and continue to do so over time. But number two, that increases in living donor transplant might be a really great opportunity to increase total number of kidney transplants. This is a timeline, and it just shows some important advances in kidney transplants since the first successful kidney transplants in the 1950s. And there has been recent policies on a national level that have focused on increasing access to kidney transplantation. So two of these policies are highlighted here, and the first is the OPTN kidney allocation system of 2019 that went into effect March 15th of 2021. And this policy change intended to increase access, particularly for children, underserved populations, and difficult to match candidates. And one of the elements of this policy is that it prioritizes candidates listed at transplant hospitals within a 250 nautical mile radius of the donor hospital. The second policy to highlight is the Comprehensive Immunosuppressive Drug Coverage for Kidney Transplantation Act of 2020. And as opposed to the previous coverage of 3 years, this would indefinitely extend Medicare coverage of immunosuppressive medications for kidney transplant recipients if they do not have other coverage. And this goes into effect January 1st, 2023. And as a transplant nephrologist, we all know that we've seen cases of rejection and sadly graft loss in patients that lost coverage for their immunosuppressive medications, didn't necessarily know where or how to reach out for help, and developed severe rejection episodes. So these two policies in particular have really benefited the kidney transplant population. So how, Dr. Sodhi, did the 2019 OPTN policy update affect your center?
So for us in Chicago, we saw a bolus of kidney transplants and offers coming through to the Chicagoland area simply because there's a large number of patients listed. And the wait times can be upwards of 8 years depending on your blood type. And so all of a sudden we had a lot of patients who'd been waiting quite a bit of time get offers, and we were able to transplant them. And as a transplant nephrologist, it's a wonderful feeling to be able to offer that to your patients. The hardest part of this change was that the infrastructure that we were used to handle the volumes that we were normally accustomed to had to be adjusted in real time to accommodate the offers and the transplants that were happening. And because of the way the organs are allocated and the distance from which you were eligible to receive offers, we had a lot more cold ischemic time, and therefore that led to some more patients with DGF, and we had to accommodate for that as well, how we were going to dialyze these patients, how we were going to track these patients. So it definitely caused some adjustments to be made. I think after the initial bolus, we settled down and we got back to our usual rates, but there was a period of probably 3 months where we were just sort of trying to play catch up and get used to the new system. It's very similar to what happened back in 2014 when they redid the CAS the first time. And I think because it had just been a little bit, we were so used to the old system, and then all of a sudden it changed. But it was ultimately good. We had patients getting transplanted quickly who had been waiting quite a bit of time, and we were able to get a lot of patients off of dialysis.
Let's focus on the Advancing American Kidney Health Executive Order of 2019. It has 3 goals, and the first is to reduce kidney failure among Americans by over 25% over the next decade. The second goal, near and dear to our hearts as transplant kidney doctors, is to double the number of kidneys available for transplant by 2030. And the third is to provide more options for patients with kidney failure. So to double the number of kidneys available for transplant, if we were transplanting 25,000 kidneys a year, going up to 50,000 kidneys a year, we really have to both utilize deceased donor potential or optimize deceased donor potential and expand our living donor kidney transplant programs. So to give an idea of the gap between supply and demand, 40,000 patients approximately joined the kidney transplant waiting list per year. And last year, 25,000 people received a kidney transplant. So that was a gap of 15,000 for the year of patients that were eligible but did not receive a kidney transplant. And when cumulative years, when patients joining the waiting list always exceed the number of people receiving a transplant, what this adds up to is that currently there's 90,000 people that are still waiting for a kidney transplant. There are several reasons that we should focus on increasing access to living donor kidney transplant beyond just the gap between supply and demand. And the primary reason is because living donor kidney transplants last longer than deceased donor kidneys. So you can see on the graph that the projected median graft survival half-life of a living donor transplant of over 19 years greatly exceeds that of a deceased donor transplant of 11.7 years. And this is very important, not only for the recipient of the living donor transplant, that they may have a better post-transplant outcome, but again, with the knowledge that the waiting list itself is comprised of many people that have failed first, second, even third kidney transplants. And if they receive transplants that last longer, it delays their return to dialysis as well as their need for another transplant. Kidneys from live donors offer several other potential benefits. Really, the risk of delayed graft function is minimal. They have a shorter waiting time, with many achieving a preemptive transplant before dialysis or even a dialysis access is placed, so no fistula permanently in their arm. A shorter hospital stay. At my center, recipients of a living donor transplant stay 3 nights compared to a recipient of a deceased donor transplant average 4 to 5 nights. It really allows a planned procedure. So this is why living donor transplants in general go far smoother than a deceased donor transplant. And then lastly, if the center, performs desensitization, the ability to perform desensitization is there. However, we know that living donor transplant numbers have not increased over time, and that there are well-identified barriers to living donation. In educational barriers, there are language barriers. There's also educational barriers in that the recipient needs to know what the advantages are of having a living donor transplant over a deceased donor transplant to be motivated to find a living donor. There are financial barriers for the donors, such as loss of income, variability in employment benefits, and insurability issues down the line for life insurance. And then things that are not covered under a donor evaluation, such as travel, childcare, and added medical expenses. I will say that I live in a state that has a nonprofit organization called the Georgia Transplant Foundation that will assist donors with travel expenses, even for the donor evaluation to make it here if they live out of state and their recipient lives in Georgia. So there are potential programs to help, but they are varied across our country. There are system-related barriers. I think one thing that we're going to touch on is just the length of the donor evaluation and all the steps that a donor has to go through in order to be approved for a surgery that's very altruistic in nature. And then lastly, we'll explore some access-related barriers and why there are disparities among minorities, elderly patients, and patients of low socioeconomic status in achieving a living donor transplant.
So the next topic that we're going to discuss is overcoming barriers to advance living donation outcomes, the recruitment of potential donors. So Dr. Klein, I'm going to ask you this question. How does your center facilitate the recruitment of potential donors?
So we really focused on improving our living donor transplant numbers approximately 4 years ago. And the first intervention that we did was that we really focused during the evaluation, making sure that the transplant candidate had a good understanding of our current waiting times for a deceased donor transplant, as well as the advantages of a living donor transplant. I think that people were surprised to hear how long it would take them to achieve a deceased donor transplant. And the second piece of information that really struck a chord was how long a living donor transplant could last relative to deceased donor transplant. After we made that just part of our normal evaluation process, we saw a huge uptick in the number of people that had potential living donors come forward. And we also started to include information about the living donor coordinator on their listing letter.
Yeah, we have similar experience at our center. I think when the patients come in for education about transplant in general, living donations touched upon during their education session, we provide a sheet for them to give them some generalized information about how a donor would even potentially get in touch with our center, what numbers to call. And then when we do the transplant evaluation, part of what we discuss with the patient is to actively seek living donors, give them strategies to do that. If they tend to be younger, we talk a lot about using social media outlets. And more importantly, the thing that comes up a lot from patients is, well, I know somebody, but I don't know if they'd make a good candidate. And so we have to encourage them to just let us make that call. And I think that's tough for people. So we really encourage them to have anyone who's interested or anyone who's willing to get in touch with the center so that we can screen the donors appropriately and decide who should proceed through evaluation. So how can you support patients in their search for a donor? There's a lot of different strategies that are employed amongst centers across the country because this is an important part of transplantation. There are live or online workshops that educate patients and their families and friends through a structured program. For example, the NKF sponsored program, The Big Ask, The Big Give. This is a really nice educational program that centers can partner with NKF and put on a one-day symposium to allow patients to come with their caregivers, and these can be people who are potentially interested in donating or just simply family members that want to learn more about the process to become the patient's donor advocate. We encourage patients to leverage social media to share their stories. I think one of the biggest challenges for a dialysis patient is to talk about the fact that they're on dialysis. My kidney patients, and I'm sure Dr. Klein has this experience, they really don't like talking about their kidney failure. They don't like people knowing that they're on dialysis. So we have to encourage the patients to not be shy about their story and be willing to tell their story. Living donor champions are another great way to help intended recipients find donors. A lot of disease processes tend to run in families, and family members are usually the first ones to stand up and want to donate. And a lot of times at the center, we have to turn family members down simply because they carry the same risk for end-stage kidney disease as the intended recipient. And a lot of times those family members then turn into champions for the recipient. And then patient navigators. This is a designated contact from your center to guide patients and donors throughout the process. Most centers have living donor coordinators that are wonderful resources for the patients, for the recipients and the donors, mostly for the donors. And they work very closely with the pre-transplant coordinators to make that process of evaluation and workup seamless. It's important to empower your patients to proactively engage in potential donors. So you need to educate patients. Some centers say, okay, well, we have an online education link we sent out to our recipients. So some of those links include informational pages. Some of them could just be short videos that the center has put together to discuss living donation. And I think it's important. Education is power. It always has been, especially when it comes to renal failure and transplantation. The more the patient feels educated and the more comfortable they are in talking about their story and sharing their story and realizing that they're not asking somebody to do something egregious or offensive. I always tell the patients, pass that link to your friends and family. Let them know what's going on. Tell them that being a living donor is going to be, getting a living donor transplant is going to be your best option, particularly for patients that have longer wait times. And depending on where you live in the country, that can be upwards of 10 years based on your blood type and where you're located. And help them find the right words. We talk to people and our patients about how to talk with people about the need for a living kidney donor. Patients feel, I had one patient tell me that he's like, I don't want to be a used car salesman. I don't want to, try to sell somebody on helping me. And, you have to remind your patients that people who are willing to donate tend to be quite altruistic in nature. And a lot of people think about donation and want to help others in need. And a lot of times they don't really know anybody who specifically needs a kidney. It's just something that they have sitting in the back of their head. And then when the opportunity presents itself, it's amazing how people step up.
One of the tips that I learned in the past is that you don't have to say, would you donate a kidney to so-and-so, but rather, my husband needs a kidney transplant and we were told at Piedmont that he'd benefit the most from a living donor. Would you help me spread the word that he needs a transplant? And asking people to help spread the word that somebody needs a transplant is a lot easier and accepted by people. And then people that actually would be interested in donating, the automatic reply would be, well, what about me? Like, what would I have to do to be considered as a donor? But if they felt uncomfortable or if they knew they had medical conditions and couldn't donate, then of course they're happy to spread the word that that person needs a donor. So there's a lot that you can do during, a sit down with people in order to help them feel more comfortable with asking other people about being a potential donor. In terms of barriers to living donation, how is the evaluation process a potential barrier to living donation? And this roadmap just gives you an idea of everything that a living donor has to go through in order to give up a kidney and on behalf of their loved one. Every program is going to have a different number of steps, but the number of steps in any evaluation for a donor is going to be lengthy. There's an initial screening process, which probably will include a medical history. There's blood tests, physical examination by a nephrologist and probably a surgeon, a psychological evaluation, a social work evaluation, imaging tests, including IV requirement for a CT scan, the consent process, final review, and last but not least, actually having to undergo a surgery that they didn't necessarily need from a medical standpoint, but are having a benefit from a psychological standpoint in being a donor. So I would just encourage all of you to think at your particular center, how many steps are involved in the living donor process, and also to really analyze your data and say, where are we seeing dropouts? People that initially came forward as a potential donor, where is the area of greatest dropout observed? Would you expect it at that point? And also what time points you have from getting from that initial screening process to scheduling surgery? And is there any way to make that time frame shorter? So I think a shorter time frame not only benefits the living donor, who of course would want to get through the process as soon as possible, but also just recognize that for the recipient, people have a limited window of opportunity for transplant. The mortality rates for people on dialysis are very high, and people that are healthy enough to be waitlisted for a kidney transplant, they have a better expected survival on dialysis, but yet you see that many people come off the waiting list because of changes in their medical condition where they're no longer a candidate for transplant or sadly death. So every transplant care team has slightly different components. Every program really will have a living donor nurse coordinator, surgeon nephrologist, and independent living donor advocate. Some centers will have a particular psychiatrist to evaluate donor mental health. And then some programs will have a living donor facilitator, so a primary contact for all recruitment and initial screening. And one thing that we did at our center that really helped fast track living donors, as I mentioned, we really wanted to decrease the time from that initial living donor contact with our program and living donor surgery, is we found out that what was happening was we were doing the full recipient evaluation, and then we were stopping at that point when the recipient was ready for transplant, and then we were starting living donor evaluations. And we recognized that sometimes when we were doing the living donor evaluation, something would happen with the recipient that would then put a hold in the whole process, and it wasn't very cohesive. So what we ended up doing was we assigned a living donor recipient coordinator, so that anybody that has a living donor that's passed through the first step of the medical screening questionnaire actually gets transferred to the living donor recipient coordinator, so that coordinator can keep a closer eye on the recipient, and the donors and recipients are pushed through to transplant together, parallel, rather than one right after the other. And we found that, particularly for our older candidates or people that had more medical conditions, we were more successful in achieving a living donor transplant for those folks. So living donor evaluation testing is somewhat similar from center to center, and there are going to be some things that are almost universal, such as people with diabetes are not approved to donate kidneys, but there are going to be elements that differ from center to center. So one of those is blood pressure. At Piedmont, we allow people greater than 50 years of age on a single agent with well-controlled hypertension to donate. There are going to be programs that have even more lenient blood pressure guidelines, and then some programs that will not approve donors on any blood pressure medicine, regardless of age. Another factor that would vary from center to center is BMI. So at our center, we will evaluate donors up to a BMI of 35. It doesn't mean that we would approve them at 35, but we want to actually take a look at them. What is their central obesity? Do they have any other elements of metabolic syndrome? Or are they just an extremely young muscular male? For example, with a BMI of 34. So, one thing to think about is to reevaluate your criteria for living donors based on most recent kind of published experience with living donors and how that would impact their risk of kidney failure down the road after donation. I find that sometimes programs, both on the recipient and the donor side, don't routinely say, we've been doing this way for a decade. Is it time to change and time to adapt? So one of the things just to think about is what criteria does your centers use for approving or excluding living donors? And is there any flexibility in that? One thing most recently that's come up is COVID-19 vaccination. So there's strong support for COVID-19 vaccination in organ transplant candidates and recipients. The ASTS, AST, IHLT all recommend that eligible children and adult transplant candidates and recipients be vaccinated. We moved towards this several months ago. Recently, as of March 1st, we required them to be up to date with boosters. And this is because, unfortunately, in January with the Omicron variant, we saw we had several people in the first year post-transplant die of COVID. Respiratory failure, direct COVID-related deaths. And one thing that we haven't done is require COVID-19 vaccination for donors, with the thought that they are not on immunosuppression and therefore wouldn't be as great of risk as our recipients. However, we have strongly recommended COVID-19 vaccination to our donors because, and this is experience that's been seen nationwide, incidental COVID on preoperative testing has delayed so many kidney transplants nationwide. And this is on behalf of the donors and recipients. So I'll ask you, how has the COVID-19 pandemic affected your transplant program?
So we actually had a similar experience that you did at your center. And this was, this is such a polarizing topic depending on who you're talking to and where you live. We do recommend that our transplant recipients be vaccinated and boosted for the same reasons that you mentioned before. And we also do the same thing you do with donors, where we don't require vaccination, but we strongly encourage it. And this has sort of been a point of not contention, but just general confusion, I think, as to what to do and what advice to give the donor population. The donor population is certainly a healthy population of people. One could argue that our general nephrology colleagues have seen a lot of acute kidney injury in COVID patients who are not immunocompromised. And the risk of acute kidney injury, should they get COVID after donation, is real and is there. And I think the best thing you can do at your center is to educate people about what the real-time data is showing and, inform them of the potential risks and hope that, they never go through anything like that. Try not to exclude or discourage people from donation based on that. So the next barrier we're going to discuss is how to improve access to donation. There are biases and other barriers that limit transplant opportunities for African American and Latinx people, and this has been well described in the literature. There are potential transplant disparities that are present. And they fall under various categories. Some are related to insurance and access related challenges, lack of transplant education and health literacy. Health literacy is so important because there may be other things like the next line, which is a language barrier, where you don't know if the patient that you're talking to is fully grasping what you're saying simply because English is not their first language. Socioeconomic status plays a huge role in transplant opportunities for minorities, and that's been well described as well. Genetic etiology of kidney disease. This is a very exciting time to be a part of nephrology because there's a lot of genetic tools that are available to help underscore and elucidate the causes of the genetic components that could contribute to chronic kidney disease and development of ESRD. And, if you do happen to find patients that may have a genetic component, then that affects who can donate to them and what are the risks of recurrence of disease versus that disease running in the family and having potential donors be eliminated from donation. Distrust of the system is always real. It's always there. We do our best as providers and as a population of people that are empathetic and want to help to eliminate, discrepancies and biases, but they're always there and they always will be. And so gaining trust of patients, giving them assurances, which are hard to give sometimes, and answering questions as honestly as you possibly can help to eliminate some of that. Sometimes patients want guarantees that everything's going to go perfectly, and it's hard to give that to people. And when you can't give that to people, it does generate some distrust. There are cultural ideologies that run in different patient populations, and we saw that very recently with COVID. Certain populations of people had facts that they thought were facts that were spreading around about the vaccine, about the disease in general, that were so polarizing and opposite. And it really affected how people thought about their health, how they thought about their healthcare providers. And these are barriers we are just going to have to learn how to overcome. And then low rate of referrals or delayed referrals. So there's nothing that breaks your heart more than a person who comes to you 2 months after starting dialysis who's known that they've had CKD 4 or 5 for a few years, because their wait time basically started 2 months ago rather than 3 years ago when they had a GFR less than 20 and they could have been accruing time. So educating your general nephrology counterparts and not just the physicians, but their entire system, their social workers, the dialysis units, nursing staff, as to who would make a potentially good candidate and when to get that referral in. We know that African Americans make up 33% of the kidney transplant wait list and have 46% lower odds of receiving a living donor kidney. And this may just be because a lot of their family members may carry the same diseases, may be ineligible for donation. They tend to associate with people within the same socioeconomic status, and therefore have the same barriers to healthcare that the intended recipients have. So there's a number of things that go on in that population that can prevent their access to living donors. Latinx people have 1.3 greater incidence of kidney failure than non-Latinx white people, but do receive fewer kidney transplant for a lot of the same reasons that we've discussed. So Dr. Klein, what has your center done to improve transplant access for underserved populations?
Well, we really focused on the Hispanic population, the Spanish-speaking population over the last 5 years. Previously, we had almost no literature in Spanish. We have 2 nephrologists that are fluent in Spanish, and we have 1 surgeon that is fluent in Spanish. And we really took all of our literature in terms of our living donor booklet, our candidate booklet, our post-transplant booklet, and translated everything into Spanish, and then had those individuals review it to make sure that it wasn't just a word-for-word translation, that the concept that we were trying to convey was appropriate. Because sometimes when you just send something for a translation, the meaning is altered. And so, we really reviewed that. We were able to do our transplant education video. We have it subtitled, and with the hopes that we can just at some point redo the video entirely in Spanish. So we really focused on that. We have a very large African-American recipient population. And in terms of living donation and kind of promoting it specifically in that population, we found that our transplant mentorship program was a great place. We had several people that felt comfortable sharing their stories about how they looked for living donors. And some of them had exactly the challenges you were talking about.
And again, we echo your experience. We have a large Hispanic population, a lot of whom are undocumented, in fact, and don't even think that they could be eligible for a transplant in general, let alone a living donor transplant. And so to try to reach that population, we're fortunate enough that almost all of our surgeons are fluent in Spanish. Many of our social workers are fluent in Spanish. Actually throughout the whole organization, top to bottom, even schedulers. So we try to utilize them as much as possible. Our surgeons have really stepped up and tried to do some community outreach with going into these Spanish-speaking communities, and really, I think, hearing things in your native tongue, like you said, when you're using an interpreter or you're trying to translate literature, some of the meaning gets lost because you can't really do a verbatim translation. And I think the patients feel more comfortable hearing things from people that can speak to them on their level and in their native tongue. They just there's a comfort there that I can't provide. We've tried to, the nephrologists in our group, unfortunately, are not fluent in Spanish. So we utilize interpreter services, and what we've tried to do is use the same few interpreters for all of our clinics. And now I think the interpreters are better at giving the education at this point than we are, because they've heard it so many times from so many people, and they know exactly where we're going with our thoughts, and they're really able to communicate the patient's concerns and fears, educating people about the fact that living donors don't have to be relatives. that is a very common misnomer that we see in minority populations. They assume that you can only get a living donor from a family member. And so they automatically know that if, like you said, if everybody in the family has diabetes, that they just think they're ineligible for a living donation. And so we have to kind of work to dispel those myths.
Another barrier we wanted to talk about was incompatible donor and recipient pairs. So if people have a loved one, friend that wants to donate, but they're incompatible due to blood type or HLA, what are the options? So paired kidney exchange has really taken off in the last decade, and so grateful for the many paired exchange programs, both single center as well as the national exchange programs that have facilitated transplants. On the left-hand side, you see a most simple paired kidney donation where one donor recipient pair are incompatible, second pair incompatible, but donor one can give to recipient two, donor two can give to recipient one. And this is how paired exchange was initially done. If you do chain donation, you can start off with a non-directed donor or somebody that doesn't have an intended recipient, or otherwise termed altruistic donor. They give to a recipient, and that recipient's incompatible donor continues on the chain. Chain donation became really popularized with some television shows, including Grey's Anatomy and whatnot. And I think chain donation became really almost a household term, and brought kidney transplant and paired donation to light. So really, paired kidney exchange is now not even limited to incompatible pairs. So sometimes compatible pairs are now being entered in paired kidney exchange programs. And you could ask, well, why would we do that? And the reason being is that you can get a more advantageous kidney for your recipient. So say that a mother wants to donate to a child that's 25 years younger than them, you could potentially get a younger kidney offer for that child than the mother's kidney, and the mother's kidney could benefit somebody such as a highly sensitized patient that's going to wait longer for a compatible match. Another reason would be just size mismatch. So although our surgeons aren't worried about mild size mismatches, if a donor is less than half the weight of the recipient, we start to get concerned that perhaps that kidney is not the one that the recipient needs, even if they're compatible based on ABO and HLA. So really, paired kidney exchange has facilitated thousands of transplants that otherwise could have never happened. And we start talking about the option of paired kidney exchange early on in the donation evaluation. So we happen to use the DASH program for our donor intake, and it asks on the questionnaire if they're interested in paired exchange if they're not compatible. We don't necessarily do a cross match until they're here for their donor evaluation, unless they indicate that they would not be okay with paired kidney exchange. We talk to them about it first, rather than just accepting the no on the questionnaire. You mark no, can you tell me a little bit about that? We really want to keep the option of paired kidney exchange open with as many donor recipient pairs as we can. So the voucher program can facilitate donations that may not otherwise occur. So there are different voucher programs. There's a standard voucher, family voucher, and the paired kidney exchange program that you're utilizing will have different options. But for example, say that you have a donor that is a school teacher, and they want to, donate during summer break because it's just easy. They have time to recuperate. They would prefer it that way. And the recipient, their intended recipient, is not ready yet for transplant. So they can donate and then name their intended recipient as one of the voucher holders. But in case that recipient becomes too sick for transplant, is not transplanted, there are other voucher recipients that could receive that kidney in the future should they need a transplant. So voucher donation is a way that donors and recipients can be separated in time. And also, say that you know somebody that has already received a kidney transplant. and you would like to donate to them, but they don't need a kidney right now, but you anticipate that that kidney eventually will fail and they might need another transplant down the road. You're healthy enough to donate now. It fits with your time frame. You can donate at this time and then name them as a voucher recipient. So the voucher program is a very neat innovation that allows uncoupling of donors and recipients with time. So one question is, how else can we help incompatible pairs and compatible pairs to expand our options? And how can vouchers help donors who are caregivers?
Well, I think I'm going to tackle the second question first. We have utilized the voucher program extensively for this issue. Donors who are caregivers pose a problem in the sense that you don't want both your patients to be recovering at the same time. So the voucher program offers donation in advance so that, for example, if it's a husband and wife and the wife is a recipient, the husband wants to donate, he can donate first. And the wife can sort of help him recover from his donation. And then once he's recovered, then the wife through the voucher program can receive a living donor kidney from another donor. And then the husband, who's now recovered from his surgery and healthy enough, can take care of his wife and allow her to get to her appointments and do all of her follow-up. So that program has been extensively useful for us because sometimes based on your socioeconomic status, there's not 12 people waiting in line to take care of everyone when you go through these major surgeries. And, people have to work and there's issues with time off of work. And sometimes a family can't afford for both parents not to be working for a month or two. So this is a really great way to get around that issue. And I think just helping incompatible pairs and compatible pairs expand options.
So another thing that's really helped with the incompatible pairs and entering them into paired kidney exchange is to also emphasize that they're not only still helping each other, but they're helping another incompatible pair. So I think people, again, it's just not intuitively obvious to them, but once you explain it, that this helps another pair that really wants to, be transplanted, but they're not a match for each other, achieve transplant, then the donor, can feel somewhat better at many times about giving their kidney to a stranger and accepting a stranger's kidney in return. I will say that the paired exchange programs have done an incredible job in just expanding options. One of the other things that has been done is subtyping A donors. So if it's an A2 donor, making that donor available to, programs that they would accept that for one of their O or B candidates, for example. I think that's wonderful. And one of the things that doesn't necessarily expand an option, but may result in prolonged lifespan of that organ transplant is, facilitating better level matches. So, for example, if you're compatible with your donor, but you and your donor are willing to enter a paired exchange so that you can get a better match, and perhaps that kidney will last longer. That's also been done in the paired exchange program. So I think that just helps to optimize the living donor experience.
I agree. And the last barrier we're going to discuss is engaging donors to prevent dropout. And this is a real problem that you see in most living donor programs, and a frustration that we often encounter is how do we keep these donors engaged through the process? At what touch points do you observe the greatest dropout in your program? So I can tell you in our program, a lot of times it's at the very beginning. So a lot of people tell their, family or friend, like, oh, I'll give you my kidney. Don't worry. I'll donate. And the number of people that actually call in and want to get worked up for that is not the number of people telling the recipient that they're going to donate. So just trying to capture that motivation and flip it into something that's more than just words, that's actually action, is, I think, the first step. And then, getting them through the process in our center, there's still things that I think are not keeping up with the times. So we send out a written questionnaire. And in 2022, not a lot of people want to fill out a written questionnaire and send it back by mail, or even scan an email. So, coming up with innovative ways to utilize smartphones and coming up with questionnaires that are phone compatible, that are approved by your center, just utilizing technology in the way it's meant to be utilized in every other aspect of our lives to get people through the donation process, and really making things as easy and simple as possible, is key to keeping these donors engaged. If you have to, for example, in our job, I'm usually never behind a desk. For most of the day, I'm never behind a desk. And so if somebody gives me a task that requires me sitting at a desk, it might not happen for several days because I'm always running around. And a lot of people's jobs are like that. People work on their feet. They're not really in front of a computer. So, but everybody's got their phone in their pocket. So we've tried to utilize some of that. The attrition rate, this is a quote from a center that was asked this question, and the attrition rate is pretty high, going from almost 1,000 people filling out forms every month to actually only 100 people donating annually. And this is a common tale that you hear at centers across the country. Dr. Klein, do you have a similar or a different experience with this?
Right. So funny thing is that for us, the pain point is the 24-hour urine collection. And I remember as a medical student being given a jug and said, collect your urine for 24 hours. And we were like, really? And anyway, so many of us had an inadequate 24-hour urine collection, as assessed by milligrams of creatinine per kilo weight. And really, that's a pain point for us, is people that are unable to do a 24-hour urine collection. We do have a glow fill option to measure, creatinine clearance in people unable to do a 24-hour urine.
Donor retention is also, something that we think of. So once you get them in the door, how do you keep them engaged? So, what strategies or tools do you think promote donor retention? So, for us, we try to make their visit as compact and efficient as possible. So, are you a center that spreads the love over several days with the testing and the evaluations, which some patients like, some patients don't. Some people just want to get it all done in one day. And that's the strategy that we've employed, is we try to get as many people to see them as possible at their one visit, do as many labs as we can. We try to get their EKGs, chest x-rays done on that visit. And then any specialized testing that needs to be done, we try to get it done as quickly as possible and minimize the time between the visit and the additional testing, because the reality is motivation can wane if there's a big lag time. Sometimes when we go looking for stuff, we find stuff that you wouldn't know you had otherwise if you weren't going through the donation process. And, things, very real, serious medical conditions can be found through the donation process. Things like cancers or, anatomic abnormalities that patients didn't know they had, and that may halt the donation process and require referral to a specialist, or exclude them from donation altogether, and then require them to be set up with a specialist for lifelong follow-up of a chronic medical condition they didn't know they had. So I think laying all these expectations out at the beginning is very critical. Dr. Klein, what about you?
Yes, one thing that we did in our program was that we set the internal expectation that a motivated recipient and donor pair that were compatible, so not dependent on paired exchange, we should be able to transplant them within 3 months. So again, we kind of work up the donor and recipient to the greatest extent possible in a parallel nature. And we also have some of our most experienced dedicated coordinators working in the living donor program, because you need people that are constantly pushing the needle for living donation to be on that living donor side. My living donor coordinator that I've worked with for 7 years, she will find me no matter where I am. She will call me, text me, bug me about this cross-match, that cross-match, this offer. And she is on it. And I think that that really benefits the living donor program, is to put your top-notch coordinators in the living donor program and to say, team, we're going to facilitate these transplants in this time period and make it happen. All right, lastly, we're going to talk about education and the protection of transplant candidates and donors. Explore what educational protocols do you have in place to prepare your donors for surgery and beyond? How do you talk about risks and rights in conversation with donors? And what tools and resources do you recommend for risk assessment? So living donor programs are designed for donor safety. So everything that we do in the medical evaluation of a potential living donor is to assess risk, particularly of kidney disease and ESRD post-donation. So communicating to the donor helps to alleviate the donor's concerns. And I will say that we use a variety of different risk tools. Risk educational tools. We talk to people about lifetime risk of ESRD in the general population, historically in living donors, and the estimates in people that are healthy enough to donate but do not donate. The website on the Hopkins page where it talks about for an individual's risk of end-stage renal disease based on demographic factors, so sex, age, creatinine. I think that that's really helpful. We don't use that to make decisions at my center, but we do educate every donor that that tool is available. And I also tell them that if we have concerns about their risk of kidney failure and end-stage renal disease, we will let them know, and we will, we have the option to tell them that they can't donate a kidney. I think that sets the stage in case we do find something that prohibits them from being a donor. And it also lets people that ultimately are healthy enough to be considered as a donor, that we have really thought about that very carefully, and assess that for them. So what about you? What has been your process for risk assessment?
Some of the same things, the transplant models on the Hopkins website has been quite useful. We don't use it for every patient. We certainly don't use it in our selection process, but I think there are patients sometimes that come in and they're really genuinely concerned about what is my risk? Or if it's, for example, if it's the recipient is a mother and it's her adult child that wants to donate. Mom is always very hesitant to take from her kids because what if they would need a kidney? Even if it's a cause of kidney disease that the child doesn't have, or maybe it's something genetic that they didn't inherit. So sometimes it helps to just pull those models up in the room and show them based on your demographics that presence of hypertension, presence of smoking, age, height, weight, all of these things, and give them hard numbers to sort of look at, because I think that helps to alleviate a lot of fear. I think, donor safety has to come through in the forefront of any donor evaluation. And, Dr. Klein and I both worked at Washington University in St. Louis at one point, and we had a wonderful person there who was doing our living donor evaluations, Dr. George Gerard. And as a fellow, I used to follow him into the rooms and listen to how he explained the risk. And he always used to say to the patients, and I find myself now saying this, so I don't know if he'd be happy or sad about that, but he used to tell the donors as he's evaluating, my job is to protect you from me, to protect me from you, and to protect you from yourself. And when he would say that to people, I think it really touched home as to, what this process really entailed. And, I always tell the patients, if you're declined, it means that your safety is in question, and we would never want to compromise your safety. And I think when you explain it in a way that makes sense to them, they're much more willing to stay engaged in the process.
So the OPTN guidelines require at least 2 years of follow-up reporting for kidney donors. But beyond this, how does your center help facilitate follow-up care for donors beyond 2 years post-transplant? We talk about with any donor candidate that's coming forth for evaluation, what do they do for routine health maintenance? Do they see a primary care physician regularly? Are they committed to checking their blood pressure, having an annual exam, having annual labs? And I talked to them about the fact that after 2 years post-donation, we will no longer follow them in our clinic, but that it is so important to have regular follow-up with the primary care doctor. And I really use that as part of my assessment. If a person isn't committed to it, honestly, I am less enthusiastic about approving them as a potential donor, because diabetes and high blood pressure being the two leading causes of kidney failure in the United States, they're both relatively silent diseases until they're advanced. So I want to make sure from my standpoint that, first of all, I'm more encouraged when patients already come forth and they're already doing it. They're up to date with their health maintenance, their mammograms are done, their pap smears are done. But if they're not, if they show willingness to do that after donation and they understand the importance, I think it just speaks volumes. How about you?
I think it's a lot of the same. You know, it tends to be the younger donors that you kind of have to cattle prod a little bit about the importance of follow-up care. And, you know, studies have shown that the best predictor of follow-up care post-donation is your visits to the number of visits you had to your PCP pre-donation. Right. So if you tend to be a young, healthy person, you may not even be established with a primary care doctor, because most people don't really establish until they develop a chronic problem. And so just stressing the importance of that. And I think it's critical, actually, and it's becoming more imperative in an era where we are pushing the boundaries of who we accept donated kidney from. So people with higher BMIs who may be donating to diabetic family members, or even if they're not donating to a family members with diabetes, people whose BMIs are over 30. You know, a lot of times people are highly motivated to lose weight for transplant or for donation, and then you see the weight start to come back after donation, and that's a tough, you know, thing to watch. And so trying to encourage them to take control of their health, implement exercise, you know, that's really important. If you see somebody coming in who says, well, yeah, I already exercise, you know, that's the easiest patient to feel comfortable about, because if they're committed to that in their lifestyle already, the odds are that they'll do very well. And, you know, we always tell our patients, if you do donate a kidney, make sure that if you ever end up in an emergency room, you let somebody know that you've donated a kidney, even if it has nothing to do with your kidney, if you broke your wrist or, you know, because you have to sort of teach them that they are now a special population of person, and they have donated an organ, they're down to one kidney, and that will be present in all aspects of their health. And so I think just continued education and stressing the importance of preserving your health and really taking care of yourself and taking pride in your health is paramount to living donation.
Yes, and also having the living donor coordinators be accessible for any questions related to kidney issues beyond 2 years post-transplant has been key as well. You know, that we don't want our donors to feel like, oh, 2 years has passed and we're not here for you anymore. So our living donor coordinators have had questions from people 10 years post-donation, and we help them, you know, to the greatest extent that we can. So financial protection for living donors has really come to the forefront in many states in terms of legislation. So a recipient's Medicare or private insurance can cover the donor's medical costs in terms of eligibility assessment. So the donor evaluation, the CT scans, the laboratory testing, surgery, and the immediate postoperative care, so the hospital stay. But there are so many costs that aren't covered. So for example, lost wages, whether or not they will remain eligible for life insurance, and then other costs including travel, childcare, pet care, transportation, should they be coming from another state to donate, lodging, for example. And I will say that I was so proud to see that in my own state, there's legislation that has gone through the Senate and it's awaiting going through the House. But really to expand financial protection for living donors, including living liver donors, living kidney donors. And this helps them to access lost wages, ensure eligibility for life insurance, and a tax credit the year of donation. So I was privileged to speak before the Senate on behalf of this bill. And I understand that there is similar legislation being introduced in states across our country. I think that this is really, really critical to support. So if you are living in a state, to help support legislation of this sort really will help living donors access things. I have heard so many stories of people, for example, if you're the breadwinner of a family, your younger child or a relative needs a transplant, and you're willing to donate, medically eligible to donate, but you actually cannot afford the wages lost due to that donation procedure. Or if you lose your job, you'll lose your insurance. So these are real barriers for people in achieving a living donor transplant. What are the sources of financial support and resources that you recommend for donors? In my state, we have the Georgia Transplant Foundation, which is a nonprofit organization that assists donors and recipients with issues like medication expenses, lost wages, travel expenses, which is excellent. Not all states have this. So, you really have to know by your state what options you have in order to help donors achieve donation. What's available in Illinois?
So we utilize the American Kidney Fund for wage reimbursement quite a bit. And it's a wonderful service that they provide. The Illinois Transplant Fund also participates in this. We're very lucky at our transplant center that we have a really good financial coordinating team and a very good team of social workers that sort of help not only guide the donors, but the recipients through this, because oftentimes they are in the same family and all of this is tied together, and one cannot donate to the other without all of these things being looked at and taken care of. Illinois, not as good as Georgia as far as having sort of state funded initiatives that can help with this, but it's not exclusive to Illinois. Even in Missouri, there were certain organizations that had better tools available than others, but it just varies on your center and what's available in your state.
Protecting living donors is definitely the priority of transplant programs and should be our priority as a country. The National Kidney Registry, which is one of the paired exchange programs, has a donor shield program, which offers key financial protections for donors, including lost wages. And the American Society of Transplantation Circle of Excellence program recognizes companies that support the wages of a living donor. So I think as we focus more as a transplant community on living donation and promoting living donation, enabling people to donate that are medically ready for donation, willing to donate, but have these barriers is really going to become the focus. The AST, ASTS, and AAKP believe no person should be discriminated against for the noble decision to become a living organ donor, meaning no donor should face disparate treatment or hidden penalties for selfless act through a threat to their job, security, or career, or their life, health, and disability insurance or related future insurability. And all of us in transplant can definitely stand behind this statement. So we will end the program here and looking forward to, a very interactive question and answer session. Hi, everybody. Thank you for taking your time out today to watch our video and just hear our thoughts about increasing access to transplantation, particularly living donor kidney transplant. I wanted to start off by just noting some of the comments in the chat. For those of you that have not been following the chat, we had several excellent comments. And the first one was from Dr. Cooper. And it was talking about kind of just how you frame living donation when you're meeting with a transplant candidate. And really starting the conversation during the evaluation of the potential candidate and not asking necessarily, do you have a living donor, but who is going to be your living donor? So just that simple change in the way that you talk to patients can make all the difference because they're just automatically thinking about it differently. Like, oh, well, maybe I could consider this person or that person, and just instead of just automatically saying no. And then, as he points out, really making sure that your center has the resources to back it up. to give education to potential donors and to help them. For example, maybe your transplant program has a living donor champion program where you can train people how to be a living donor champion and spread the word on behalf of somebody that they need a transplant. Also, Dr. Cooper had another comment about, dedicating, or I guess setting aside your living donor program to make it not just fit in other pieces of a busy transplant program. And I feel like that's where we've been really successful in my own program. The living donor program, I work with them very carefully. I actually only work with living donor and the living donor recipient coordinator. But that means that at any given time, if we get 3 offers through NKR, which is the paired exchange program that we work with, I'm like ready and available to work through those offers. If we have a fast track placement to our wait list, we find the patient. And the only way that I can do that, honestly, is because our living donor team knows these people so well, even including our living donor recipient coordinator. And I feel like they help guide me. They know what offers have fallen through. They know what cross matches have not come to fruition. And we're just a small but concentrated focus on living donor. And it does feel somewhat separate. And I feel like that helps tremendously. I will also add that one component that's been super successful in our living donor program is involving our HLA team. So our HLA medical director, we meet approximately once a month with our living donor team to talk about pairs that we have in paired kidney exchange, and particularly sensitized patients. We've run surrogate cross matches. We've used cross match experience with deceased donor offers, things like this in order to modify how a candidate is listed in paired exchange for avoids. Some paired exchange programs, you can order a cryo cross match or an exploratory cross match with a potential donor before an actual offer is made, and that's been super helpful too. So I have found that we've just had great experience with, a really focused living donor program. Would you like to share your experience as well?
Yeah, I think that so the comments that have been coming through actually have been really nice. And, Dr. Cooper brought up some really good points, and you've touched on a lot of them. I think it is imperative that you have a dedicated living donor staff. Without a dedicated living donor program staff, I agree. I think it would be really hard to ask other members of the team to facilitate that while doing other things. I think to have a successful living donor program and just facilitate living donor transplants in general for the country, you have to have dedicated resources for that. I think it's important that, we do change the mindset a little bit. So the default for everybody is a deceased donor kidney transplant in this country. And I think that we are one of the few countries that are lucky enough to have such an organized deceased donor kidney program. That is not the case all over the world. The rest of the world often is doing living donor transplants, and that's how people with end-stage kidney disease have to deal with their disease as a treatment alternative to dialysis and other renal replacement therapies. And I think we get spoiled by UNOS and how wonderful they are and how effectively the organ allocation system is here in this country. But living donors should be the first option. The outcomes, the data is so good on living donation. It's best for the patients. It's best for people that don't have the resources for that, and makes more of it organs available to everyone. So I think there is an importance in shifting the mindset to say, who can be your donor when you're doing evals for potential recipients, rather than just saying, okay, well, these are the tests you need to get done in order to make it onto the list. And then, this is your wait time for an organ. That is everyone's default. So I think it is really important. I know that there are so many different initiatives that are out there. Big Ask Big Give was great at the center I was at before I came to Chicago. We did a symposium once like in the fall and the spring, and we had families come out, share their stories, hear from people who had gone through the donation process. So I can't say enough about that program. It worked really well for us. We did a living donor champion program as well. I think there's no easy way to do this. I think it's just getting yourself and your program and your resources into the communities and really talking to the patients and their families and the community in general, because when one member of a community is hurting, I think everybody tends to want to rally around that person and try to help in a meaningful way. And I think there are a lot of people that can do that. They just need some guidance on how that can be done. And there was another comment that came through. There were two more comments that came through. One was from Dr. Kumar that was saying, we touched on the COVID policy of donation and how sort of controversial that was. And she said that the risk of a healthy donor contracting COVID and living with one kidney is real. And it maybe is something that we should be stressing a little more to the donors. While it's not a requirement, we certainly did hear stories. I know we did at our center, and Dr. Klein, I'm sure you did at your center, of people who would come through for eval for kidney transplant who said, well, I was fine, and then I got COVID, and then I started dialysis, and I never came off. So we had some AKIs that just progressed to ESRD, and we're still learning all about this disease. So I think educating people on the risks of now you're down to one kidney, should there be a new variant that causes another surge that is potentially harmful, that the vaccines may not be 100% effective against, you are now down to one kidney, and you need to think about what is best for you, what's best for your health, and what's best for the survival of you and your family. And then the last thing that we saw come through the chat was a question about integration and how you coordinate between a transplant center and some of the community resources and making partnerships. So Dr. Klein, I'll ask you how your center at Piedmont works with community providers, both primary providers as well as nephrologists, to sort of facilitate improving those relationships.
Well, the question I think you're referring to came from Dr. Potts, and I'm really been thinking about it ever since he posted the question. A great opportunity for centers and health plans, particularly integrated systems, to develop closer partnerships in finding living donors. And I'm going to assume that Dr. Potts is from Kaiser, and I'm really thinking about this. And the Kaiser system obviously has members throughout our country in different areas. And what could, for example, a health plan system do to help transplant candidates and potential donors achieve a living donor transplant? I think the first part, really focuses again on the education piece, both of the candidate as well as the donor. But the second piece, and this isn't focused on Kaiser, but what I've seen at our transplant program is that different health plans have different requirements themselves in order for us to list a patient for transplant. So for example, we've had some candidates that go through all of our listing criteria, but then we submit for insurance approval and the insurance plan says, we require this and that for that patient to get listed. And certain things like a Panorex, which isn't easily available at Piedmont, can be relatively tricky to obtain just to get that person on the list. So this goes back to our previous conversation about the different steps that a living donor has to go through in order to actually make it to surgery. If it's a multi-step process, what can we do in order to facilitate, those people having expedited testing approved? If you have standardized testing that's agreed upon between a transplant program and a health plan provider, and then it's easy for both the recipient and the donor to get that testing actually achieved. Anything that you can do to rapidly expedite a donor or recipient evaluation is going to improve the chance of a living donor transplant. But that's something that I need to think about longer, just because it's a really great question. Any thoughts that you have on that question?
Yeah, I saw that pop up and I was pondering that as well. I thought, wow, what a great question for a health system. You touched on this a little bit, but something as simple as dental clearance, forget the Panorex, just having a dentist available to see patients and clear them is difficult. And a lot of people can't afford that, just even for a routine dental screening. And so, implementing some of the steps. And I think if a health system is willing to refer patients for transplant at whatever part of the health system that occurs, then I think it's really important to understand what the requirements are for transplant, like you said, because there are so many tests that we can order, but there are sort of landmines that you run into with insurance companies on what they're willing to pay for, even what centers they're willing to refer to in general. And we've seen that as well, where a lot of times we'll get a patient show up at our door because they were all worked up at another center, and then their insurance company didn't want them to be transplanted there. And so there are a lot of different ways that you could sort of navigate implementing that. And I think, we've been saying education, 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 but it really is such a critical component of a living donor process, because it is not something that is, I think it's trying to become more organized in the way like the kidney allocation system is for deceased donor transplants are through NKR and other things, but it's still very much at the center level. And I think trying to standardize how that plays out, and we've even seen people who want to donate who are overweight but don't have, luckily, any signs of dyslipidemia or diabetes, and just even getting resources for them for a non-surgical bariatric program where they can go and they can get counseling on nutrition and other things so that they can optimize their health to become better donors and then continue their health after the donation, and having resources within a health system to provide that. I think these are all challenges that are coming up, and it's evolving. But those are my thoughts.
So I think that we should wrap it up here, just in the interest of time, because we're probably going to be cut off just in this era of high technology. But I just wanted to take the opportunity to thank, everybody again for joining. We can take another question through the chat, and then if things just cut off, then we'll just leave it as is. But sorry if it's choppy. One of the questions that just came through was, are you able to do 1 to 2 day evaluations for donors, especially for out of town donors? Can you share your experiences, the hurdles that you have to cross? So our evaluations are 1 day evaluations. We essentially have it timed so that each member that needs to see the donor candidate has a specific time that they're going to come to clinic and see the candidate, as well as the testing. So we do stress tests in candidates above a certain age, for example, CT scans, potentially glow fill. So depending on what it is that they're going to have done that day, we have a whole kind of timesheet planned out for that donor. And we do achieve everything in a 1 day evaluation. And we used to have a 2 day evaluation. And again, when we really considered that, we were like, why do we have a 2 day evaluation? It's such a pain for them to have to come back to our center for the second day. And we, changed it into a 1 day. And I think that again, just anything that you can do to make it easier for a potential donor, as long as you're doing your thorough evaluation, the better.
We've had the same experience. If we have older donors, they are automatically defaulted to stress tests. And so we try to get that lined up for the day of their eval so that that's done, because that's a little trickier to schedule. So we try to make their appointment date that same. Our pre-screen kind of alerts our coordinators, this person may need PFTs if they've smoked in the past, or may need to add a chest CT to their, imaging, stuff like that. And I think that helps. I think pre-screening the donors a little bit with getting some basic information can help you consolidate and sort of plan ahead for how you're going to take care of a donor eval and try to maximize and be as most efficient as you can in their 1 day that they're there, because travel time and expense is a real burden for some people, and we don't want to lose a potential living donor based on that. Okay.
So Dr. Cooper comments, we found in order to do 1 day evals, you need to have buy-in from the hospital administration to be your companion. when speaking to other departments, noting how donors expect this and how it can lead to further transplants for your program? Absolutely. So we have a transplant clinical committee that meets to talk about our abdominal as well as our heart transplant program. And we have representatives, for example, from the echo lab, from the stress lab, from the pulmonary lab, all there. And when we do run into kind of difficulties just with time management and scheduling, we address this at this transplant clinical committee level. And sometimes it just takes the explanation, we need to make it easy for our donors to do this in one day. And there's only 1 to 2 per day, and then the problem is fixed. So definitely just, speaking about it on a hospital level with your administrators can definitely make the difference. All right. Well, I hope that you all really enjoy the meeting. Thank you for joining us. And if you have any questions for me, I can be reached by my email. It's easy, christina.klein@piedmont.org. It's been a real pleasure sharing the afternoon with you.
Yes, thank you for attending the symposium. We really enjoyed hearing your feedback and taking your questions, and I hope that it was helpful to many of you out there. And I also can be reached at my email, which is more complicated than Dr. Klein's, but it is rupinder.sodhi@lumc.edu. All right. Thank you, Dr. Klein, for your time, and it was a pleasure speaking with you this afternoon.
Thank you. Pleasure to do this with you as well.